Welcome back, everyone. Today, we're diving straight into part 2 of our explainer on shoulder arthroscopy and CPT coding mastery. Now, if you were with us for part 1, you know we laid down a rock-solid structural foundation with the bones. But today is where things that truly dynamic. We're going to bridge the physical, muscular engine of the shoulder directly to your clinical coding applications. We want to show you the actual logic behind the CPT codes we use every single day.
So here's our roadmap for this explainer. We'll start with a quick masterclass recap, then we'll dive deep into the SITS muscles of the rotator cuff. After that, we'll hit a really crucial clinical coding pearl, cover the scapulothoracic stabilizer muscles, do a rapid interactive knowledge check, and finally wrap up with what's next.
Okay, Section 1, Welcome and Masterclass Recap. Let's take a quick look in the rearview mirror before we accelerate into today's core topic. Right, so in part 1, we tackled osteology and articulations. You probably remember we mapped out the 3 intersecting bones of the shoulder joint, the humerus, the scapula, and the clavicle. Those bones are basically the structural scaffolding. But, scaffolding doesn't move on its own. It needs a motor. And that brings us to step 2, our objective for part 2, mastering the muscular anatomy and dynamic stability of the shoulder girdle. We are literally going to master the muscles that act as the dynamic engine moving those bones.
Moving on to Section 2, the rotator cuff sits muscles. To really understand this vital dynamic engine, we use a super powerful mnemonic for its 4 core players, and that is SITS, S-I-T-S. Let's break those down. First up is the S in our SITS mnemonic, and that's the supraspinatus. Sitting right on top in the superior position of the shoulder blade, its main job is facilitating abduction. That just means lifting your arm away from your body. Now, because it's crammed into that really tight space right under the acromion, it is arguably the most overworked and cramped muscle in the entire shoulder. And it's exactly why, when you're looking at operative reports, you are constantly going to see this as the most common site for tears and chronic impingement.
Next, we move to the I. Shifting our perspective to the posterior, or the back of the shoulder blade, we find the infraspinatus. When this muscle contracts, it pulls the arm backward. You can think of it as the primary powerhouse responsible for the external rotation of the shoulder.
Then we have the T, the teres minor. Now, functionally, this small posterior muscle builds perfectly on the infraspinatus we just talked about. It's kind of like its right-hand man. The teres minor works essentially as a reliable assistant, helping to power that external rotation while also assisting in adduction, which is bringing the arm back down toward the body. Finally, the last S in SITS. If we look at the anterior or front of the shoulder blade, basically plastered right against the side facing the rib cage, we have the massive subscapularis. Because of its anterior placement, it pulls the arm inward, making it absolutely crucial for internal rotation. But beyond just movement, it acts as a vital anterior joint stabilizer. It practically hugs the front of the joint to keep it securely locked in place.
Section 3, the clinical coding pearl. We've seen the biological form of the 4 SITS muscles, so let's execute that critical bridge we talked about. We are going to shift our focus right now from biological form to administrative function. So here is the crucial point. Repairing 1 or all 4 rotator cuff tendons reports a single unit of CPT 29827. Why? Well, because the SITS muscle group shares a single foundational origin point on the scapula and functions collectively to stabilize the joint, coding guidelines view them holistically. Whether the surgeon is repairing a tear in just the supraspinatus, or if they're fixing a massive trauma involving 3 different muscles, you report a single unit of CPT 29827. You do not code per tendon. They function as a single anatomical unit, so they code as a single anatomical unit. This is exactly the kind of anatomy to coding connection that prevents denials, for sure. All right, Section 4, Scapulothoracic stabilizer muscles. We've mastered the rotator cuff, but now we need to look at the supporting cast. These are the muscles that provide essential movement and stability to the shoulder blade itself. There's quite a list here. We have the trapezius, the deltoid, biceps, triceps, latissimus dorsi, the rhomboids, serratus anterior, and the levator scapulae. Now, I want to highlight a couple of these specifically for you. The deltoid is critically innervated by the axillary nerve, a detail that pops up a lot in trauma scenarios. And definitely keep your eye on the biceps. In many of the operative reports we analyze, you'll see surgeons dealing with biceps tendinopathy. They might perform a biceps tendinotomy or tenodesis right alongside a rotator cuff repair. We'll be diving deep into coding those exact scenarios in an upcoming explainer, so make sure you bookmark that muscle in your mind. Section 5, Interactive Knowledge Check. All right, it's time to switch gears and get you actively involved for a second. Here is your challenge. Think back to the sits muscles we just covered. From which bone do the 4 rotator cuff muscles originate? I'll give you just a second to lock in your answer in your head.
And the answer is the scapula. This triangular-shaped bone is the foundational anchor. It provides the primary muscular attachment sites for dynamic shoulder stability. Understanding that the scapula is the common origin point is exactly how we understand the logic of treating the rotator cuff as a single unit for coding. It all connects back to the anatomy.
Section 6, Summary and Next Episode. Wow, look at the incredible ground we've covered today. You now know the sits muscles by heart, you understand the scapular stabilizers, and you know exactly how that anatomy applies to CPT code 29827. But consider this. If all these powerful muscles rely on the scapula as their anchor, what happens to your coding logic when a massive trauma disrupts the ligaments holding that very anchor in place? We'll answer that in part 3, where we conquer the shoulder ligaments, bursae, and neurovascular supply. Until then, keep questioning the anatomy behind the codes and decode healthcare with Harshal.